This is the amount of damage which can occur in 2 days in a case of penetrating trauma. In the, we will be coming to which organisms were identified, but there is no view of the retina at all. You cannot make out what is vitreous, where is retinal tissue. Such a scenario, the chances of salvaging becomes extremely remote. The iris tissue was also cut to, and iris sample was also sent for microbiological evaluation. There was bleeding inside the eye. Subsequently, the keratoplasty was done. The corneal button was fixed. The donor cornea, you can see the keratoplasty being done. I'm fast forwarding it. The basic purpose of showing this video is to show the amount of damage which is possible in a case of trauma, especially penetrating trauma. And maybe if the initial operating surgeon had given prophylactic antibiotics, this picture might have been avoided. Can we escape from the video? I just want to go. Yeah, back to the presentation. Next slide. So 4 days post-operative, you can see the graft is in position with the sutures, and there are still a few exudates in the entry chamber, but the eye looks a lot more quieter than what it was pre-operatively. The main purpose was to prevent the infection spreading to the brain and causing pen-off, so at least we could achieve to avoid that. The eye was otherwise lost, and we found that the culture was positive for bacillus species in the corneal button as well as vitreous aspirate, and the PCR was positive for both U-bacterium as well as pan-fungal genome. Patient was continued on parenteral vancomycin and amikacin for 5 days and then shifted to oral antibiotics. The course of oral antifungals was also started by the pediatrician. Eye was lost ultimately, but it became quiet and breathicicle.
Dr. Arvind,
thank you.
Please summarize. Good morning, Dr. Mehta. We welcome you.
Of ophthalmitis, I request Dr. Kanti Modi to hand him the memento. I now call upon Dr. Manish Nagpal.
Mentioned it in this presentation.
Good morning to all of you, and I would like to thank Dr. Natarajan for the kind invitation to be here. Well, I've just been told that there's this video-based presentation which was sent here, was put in the talk here, so I'm taking you over through the presentation on giant retinal tears, which is often encountered when we see trauma, and any cases following trauma at some point develop giant tears, and some of them have very bad PVR. So what I'm going to show you is a few variety of cases where different types of tears are there with different PVR settings and how we manage it in those scenarios. So the first is a typical giant tear with no gross PVR. It's a fresh tear which has come up. There is a debate about putting a buckle on these eyes, but we do prefer putting a very light indentation based buckle which does support the inferior base and prevents PVR eventually. So the first aim is to clear off all the vitreous which is there and go into the periphery. Wide angle systems now help a lot while managing these situations, because otherwise the peripheral view was limited. So using wide angle systems, chandeliers, all these things, you can see things much better in the periphery, and so you can see the edges of the tear, remove the vitreous, you can see the peripheral margins of the rim and remove it so that that doesn't lead to mechanical PVR reproliferations eventually, because all these factors are known to cause failures with the surgeries eventually, even though on table you can settle the tears quite well. Then of course the perfluorocarbon has changed the whole way that we manage these tears. because it passively just puts back the whole retina in place and allows you to see the whole retina in one go and also see that there is any existing traction or not. It almost acts as a third hand and allows you to put the retina back. So once you filled it up to the edges of the tear, you can see the margins, you can see whether they are well opposed to the underlying choroidal tissue which is there. And then a 360 barrage laser of 3 to 4 rows is done to kind of create the retinopexy all around, and also in the areas which are attached, because these cases are prone to develop future tears in other areas as well. So this, as you can see, is a full 360 view of all the tear which is back in place with the laser marks, and then you do an exchange to remove the perfluorocarbon. At this stage, some people like to do a direct oil perfluorocarbon exchange as well. We usually shift to air, and if at all there is any slippage that we encounter, we sometimes do a graded exchange with silicone oil. So once we've aspirated the PFCL and is replaced with air, we check the margins and then put back silicone oil in these cases. Now some of them would come to you already with PVR changes like this. You know, it just has a small isthmus of attachment inferiorly which is crumpling up, but the central part is still open to a large extent. And in these you might need to, after clearing off the vitreous in the center, you probably use the perfluorocarbon much earlier so that it allows you to see and assess the traction. So you put it up to the edges of the tear. Don't fill it up beyond that, because it would tend to spill over because there is still traction. As long as there is no traction, the perfluorocarbon can be filled up. But once you see traction, you need to stop short of those edges and then make sure that the traction is removed, which of course can be done using various instruments. In this case, we are using a serrated spatula, a cat's paw spatula, which helps us identify the membranes and then peel it off from those areas. After that, of course, the same procedure is done again, the laser and the exchange. Then we go to a situation which has got a much worse PVR scenario, where the central part is crumpled up. In the previous one we saw the peripheral part which had crumpled up to a large extent. Now here you see that almost the central part is also refusing to open up, and so a very guarded perfluorocarbon injection is done so that, for the same reason that it should not go retinal, because once it goes back you need to re-aspirate and restart the process again. So slowly we keep increasing the meniscus of perfluorocarbon as we remove the traction, but at some point we realize that there is a shortening of retina at this place which is not allowing us to, even though after we've removed all membranes it's not, so we decide to do a relaxing retinectomy. Before that you do a diathermy to that area so that you can reduce the incidence of bleeding, and then now you can see that it's relaxed, and you need to do a lot of laser in these cases because they do reproliferate, and more so inferiorly. So we almost barrage off the whole inferior with PRP. Then there's a situation where there's PVR with almost a 360 giant tear, which becomes difficult to manage, and here bimanuality is required because once the whole tear does not have attachment somewhere, you cannot control it. So here you need a chandelier which might be showing you the light, and both your hands you can use to actually manipulate the flaps, and as you can see that we kind of open it, and then of course once it's opened up, do the laser and do the exchange. Lastly, there is this case where there's also a nucleus chunk inside with a large tear which has formed inside. So here the scenario slightly changes because you also need to take off the nucleus, which needs a fragmentome to remove it. And once you have a flappy mobile retina, you can't use it that freely because the vacuum generated by a fragmentome is pretty high. So here we first, after clearing the anterior vitreous, put in perfluorocarbon so that the nucleus comes up a bit and also puts the retina back and keeps it safe away from the fragmentome area. And so once the nucleus is aspirated, we reassess the tears, and you can see it's a very ragged tear which has come right to the posterior arcade. So slowly we kind of evert it back and do a good laser to these eyes, and then put the retina back. These are just some pre and post-op silicone oil filled eyes. The challenge with these eyes is also not during the first surgery, but also the oil needs to be removed. So at some point these eyes would require oil removal, usually after 3 to 4 months or 6 months, or if there's emulsification earlier than that. And the way we do it is we do a hybrid procedure where we put a 23 gauge cannula and aspirate it through the 20 gauge so that the time is saved, because it becomes slow if you're doing on a 23 gauge. Now you can see here that the tear edges are well scarred with the laser that we've done. So during oil removal, we make sure that we are seeing we check the whole peripheral retina and make sure it's attached and remove it. So with wide angle systems for fluorocarbons, I think the management of giant retinal tears has become pretty much more in our hands than before, because previously to actually contain them or get them back was difficult. Lastly, also, eyes which develop these tears, the other eye needs to be looked at. They might have some lesions which are predisposing, and then they need to be lasered and checked, and any weak areas need to be lasered at some point. Thank you very much.
Thank you, Manish.
I've had a couple of cases of giant retinal tears where, although the retina has settled quite well, post-operatively I've seen 1 or 2 small PFCL bubbles under the retina.
Yeah.
Now, most of the times you just observe it and nothing really happens. But do you do anything differently?
Unless they are on the macula, I mean, very close to the macula, we've sometimes gone in during the oil removal and taken them off. But otherwise, I don't think
They can just be watched.
they can just be there. Usually they don't,
Manish,
Yes.
I want to make a historical observation. I think in 70s, the method was very dramatic for giant retinal tear. The patient was
supine,
in prone position
prone
on the
position,
table,
yeah.
and surgeon was lying down on the floor,
Yes.
and on the back. And I have seen it, and this started by John Scott from Cambridge, UK.
Yes. Yes.
And it was terrible.
Yes.
Now you made a very lucid and simple treatment.
Yeah, no, it's a long
PFCL
way.
and
In fact, we have historically some pictures at our center where this was done as well. Dad used to do it.
That's
The
right,
anesthetist, everybody used to. It was a whole revolving table with the surgeon was supine, and it was a challenge. I mean, fortunately, we've not seen that whole process, and we had.
And then the surgeon had to undergo spine surgery.
Yeah, I mean that could be done definitely. Especially if it's a larger bubble. I mean, if it's very small, it could be okay. But anything,
I'm talking about the smaller ones.
right.
Larger ones, of course, you would want to
Yeah,
remove it.
yeah, sure.
Since you're already here, then I think you can proceed with your second presentation,
Sure, okay.
Manish, and that is going to be on vitrectomy for trauma.
Okay. So vitrectomy in trauma is a huge area, but we'll just take you over through the some variety of cases which we encounter during trauma where vitrectomy is required. Dr. Natarajan was to talk on the primary and secondary repair approach, so I'm not going into the detail, but grossly we do know that while managing trauma, once there is a tear or an injury which is broken the barriers, we need to make sure that the tear is repaired first, and that becomes, of course, that you make the tissues, the viable tissue has to be put back and the tear has to be repaired. And usually we would not do a vitrectomy at this stage unless you are encountered by endophthalmitis or intraocular foreign bodies. There would be specific situations where a vitrectomy would be done as a first procedure with penetrating trauma of any sort. But usually it would be a deferred approach, a secondary approach which happens after 2 to 3 weeks is a better time. So the general consideration at that time would be whether there is media opacity in the form of cornea or cataract or hyphema, pressures. You need ultrasound to grossly judge the prognosis which is there, or